All right, we're going to go ahead and get started now. Thank you, everyone, for your patience. Apparently, there's a lot of administrative work that takes place after a vote, so June's smiling at me because she knows. So we're going to go ahead and get started. We're going to start today with the Department of Human Services, Child Support Administration, and the analysis from DLS. Turn it over to Naomi.
Thank you, Mr. Chairman. My name is Naomi Camaro. I'm here at the Department of Legislative Services to present the 24 allowance for the Department of Human Services Child Support Administration. The agency's fiscal 24 budget increases by 2.4% to $104.9 million. Exhibit 1 on page 2 shows the breakout of that total. The majority of the budget is allocated to personnel, most of whom staff the local child support service offices across the state. And then I also wanted to point out that 8% of the budget is allocated to the Baltimore City privatization contract. Baltimore City is a bit unique in that its child support services are provisioned by a private contractor with whom DHS has a contract. Exhibit 2 on page 3 and 4 shows the line item changes in the budget between the working appropriation and the proposed allowance. And I'll just point out a couple of items on page 4. First, the state call center and the state disbursement unit each decreased by about $500,000 due to an anticipated decrease in service expenditures to align with pre-COVID-19 service levels. And then there's just over $1 million increase due to supplemental information technology support for the new child support management data system. Further down on page 4 is a summary of personnel changes. I just want to point out that CSA has a relatively high vacancy rate of 13.11% as of December 31st, 2022, and a total number of vacancies is 85.5. Further discussion of high vacancy rates in DHS department-wide is included in the DHS administration analysis, which was presented a few weeks ago, so I won't go into too much detail, but I did also want to point out that out of that 85.5 vacancies, 61 of those are child support specialist positions, which is one of the classifications that received salary enhancements in November 2022 as part of DHS's compensation plan to increase recruitment and retention. On page 6 begins a discussion of child support performance. The U.S. Department of Health and Human Services sets goals in 5 different areas for state departments to work toward and then awards incentive payments based on their performance against these measures. I'm going to focus on 4 of these in this discussion. The first is the percentage of cases in which child support orders are established. The second is the percentage of cases in which paternity is established. The third is the percentage of current support paid out of the current support due, and then the percentage of cases in which the agency is collecting on arrears. Exhibit 3 on page 7 shows the statewide performance in federal fiscal 21 and federal fiscal 22, as well as those federal incentive goals for federal fiscal 22. So Maryland as a state exceeded 2 out of the 4 federal incentive goals in federal fiscal 2022 in the areas of cases with support orders and current support collections. As I mentioned just a moment ago, Baltimore City is a bit unique in the way that it provisions the child support services, just because it's gone through a private contractor. And that contract with DHS includes minimum service levels that the office has to meet, or else DHS could levy a penalty against them. Exhibit 5 on page 9 shows that in the most recently closed federal fiscal year, federal fiscal 2022, Baltimore City's performance against these minimum service levels. It met 3 out of the 4 minimum service goals. DHS has said that it's not planning to levy a penalty against them at this time, citing ongoing service interruptions and complications due to the COVID-19 pandemic. More data and information on each of the local jurisdictions' performance can also be found in DHS's JCR response submitted last fall. I also wanted to point out the total amount of collections that CSA has collected and distributed over the last several fiscal years. Exhibit 7 on page 11 shows the total amount collected between federal fiscal 2018, federal fiscal 2022, in addition to the percentage of cases in which overdue support is collected and then current support due is collected. The jump in federal fiscal 2020 is driven mainly by an increase in being able to collect on arrears, which is represented by that red line on the graph. This was mainly due to DHS's ability to intercept payments through federal stimulus income, including the expanded unemployment insurance benefits. One factor that DHS has reported will improve its service, department-wide, including for child support, is the transition to new data systems. In September of 2022, the legacy CSMS child support management system was decommissioned, and DHS is training its staff at the local offices on the new system. Exhibit 8 on page 13 shows this number of staff trained and to be trained as of June 30th, 2022. And in its written testimony, DHS provided an update on these numbers. Finally, I'll conclude that by saying that DLS is recommending to the committee to adopt narrative requesting 3 regular child support performance reports to understand DHS's performance against the federal incentive measures, as well as understanding how the new data system is helping them achieve their goals. And that concludes my presentation. Thank you.
Okay, thank you so much. Any questions for Naomi? All right, seeing none, let's bring up the department. I have Secretary Rafael Lopez and Child Support Administration Executive Director Kevin Geist-White. And whoever else.
We have an entire audience for you.
Absolutely.
Just for fun. All right. Good afternoon, everybody. Chairman Resnick and honorable members of the committee, I'm Rafael Lopez, serving as the acting secretary of the Department of Human Services for a few more hours until I get sworn in this evening with the rest of the cabinet. So we are all loving dropping the acting from our title. Thank you for the opportunity to discuss our budget with you, and I want to introduce a few folks who are here at the table with me. To my left, Cornita White, our new Deputy Secretary of Programs of the Department. Also to my left is Jeffrey Chipungu, the Chief Financial Officer, and to my right, Kevin Geist-White, who's the Executive Director of the Child Support Administration. We have a few folks also in the audience to answer any additional questions that the committee might have. We have Jarnis Johnson, the Deputy Executive for Programs for CSA, Christina Tabito, the Deputy Executive for Operations for CSA, Claudia Nelson, Director of Somerset County Department of Social Services, Lisa Beeman, Director of Cecil County Department of Human Services, and as we've been pointing out, we're being deliberate about including our partners for the Maryland Association of Social Services Directors. You've all received the written testimony, so I'll not repeat that. I'll lift up a few items to respond to our analysts' recommendations. And also want to thank Naomi for her thoughtful analysis. I will conclude, however, by bringing to your attention something that is an error that we've encountered, and I want to be really transparent about it. And what we're trying to model here is that rather than hide from the legislature, include you as partners in helping solve things, because we understand that as your constituents may call you if they are the victims of errors, and we want to take responsibility and ownership for those errors and walk you through what we're doing and what our plan is moving forward. With that said, the Child Support Administration strives to make certain that children grow up receiving support from their parents and that the family is able to maintain economic independence. And that requires, of course, our full attention on the whole family. We want to make sure that Maryland's child support program is not siloed or independent of child well-being efforts, but in fact deeply integrated to our child welfare services and our Family Investment Administration services in terms of investing in families as a whole. We certainly can't do this alone and are grateful to you for your support and know that together we can continue the integration of this work across the department. Currently, we provide comprehensive support services to approximately 189,000 children in the state of Maryland. This last year, we collected and distributed $511 million on behalf of these families. In federal fiscal year 2021, Maryland ranked above the national average in the 3 key federal child support performance measures that were also listed up by our analysts. And we want to continue that trend and also be a trendsetter around the way in which we are doing our work across the department and across the state. We support non-custodial parents with job training assistance and are looking already to be even more creative and innovative around how we do this in a more thoughtful way. And want to point out that there are a couple of programs that are specifically sponsored by us. So through September of last year, there have been 11,618 non-custodial parents enrolled in one of our programs outside of Baltimore City, representing nearly 27,000 cases. Of 16,362 cases who had a payment distribution after enrollment in the program, we found that total distributions were $217 million. And these were a couple programs that are worth pointing out, which are Winning Fathers Program in Baltimore County, Parents as Partners Program in Caroline County, Young Fathers Employment Program in Talbot County, and the Job Network in Baltimore County. A couple others include the RISE program in Caroline, Dorchester, Kent, Queen Anne's, and Talbot counties, CAPE program, which is the County Alliance Program for Employment in Washington County, as well as Networks, which exists in Somerset, Wicomico, and Worcester counties. We want to speak now to the issue of actions and issues. So we concur with the one recommended action that's been proposed, which is to provide 3 reports on the child support performance. Happy to do that. Next, on the issue of turning our attention to issues, I'd like to turn your attention to issue number 1 on page 8, which asks us to discuss whether a penalty was assessed for the missed minimum required service level. We elected not to impose a penalty because the vendor overall has improved their performance. Our staff has worked diligently with them to improve their performance and to increase communication with the department. And ultimately, we believe that we can figure this out. The pandemic forced the courts to limit scheduling court cases, and that also affected performance. So we want to be realistic about those expectations. And of course, as the pandemic draws to an end, look to being even more thoughtful in our communications with the vendor. Now to issue number 2 on page 12. DLS recommended adopting committee narrative requesting periodic reports on CSA's performance against the federal incentive objectives and utilization of the new child support system, which is the transition from the module from the legacy system over to MD Think. We concur with the recommendation and are happy to submit those periodic reports. To issue number 3 on page 12, you have asked us to comment on the number of staff that have been trained and are awaiting training as of January 1st of this year. So as of that date, all 766 staff have been trained, and we have provided details of staff by child support jurisdiction in our response for your convenience. So I'll pause there for a second and ask if you have any questions about those before I talk specifically about the error that we've encountered.
Thank you, Mr. Secretary. Any questions? I'd like to return for a second to the issue of the Baltimore vendor. And I understand all the reasons that you said, but at the same time, this is not the first time we've heard of missed marks by that vendor and by every other statistic. The department as a whole, or the administration as a whole, has had the same COVID and other challenges that the Baltimore City Department has had, yet the performance from the department itself is head and shoulders better than the vendor. So how do we reconcile that, and how do we move forward with, really the ultimate question is, do we need to keep a vendor, or can we just do it as the department?
How about I'm going to break it up in 2 components. I'm going to speak to what I've shared with senior leaders about my take on vendor contracts, and I'll have Kevin speak to what has been, because I wasn't around for that portion of the work. So let me first speak to what I've been sharing with senior leaders, which is probably not going to be a surprise to you, because I think you're getting my style, which is when a vendor of any kind, whether it's a nonprofit partner or a private sector vendor, is doing work on behalf of the people of Maryland and we pay them money, we expect them to perform. And if they repeatedly come back to us and not perform, I will cancel their contract. And if our current contracts don't have performance metrics already built in, I will change that and ask our lawyers to find better ways to cancel those contracts. So I'm really clear about that. So I want to set that tone. I intend to be a good steward of the public's money. And when they're not performing, we just change vendors. And if we don't like the vendors that we have as a result of a competitive bidding process, we try to take that work in-house. We work with our union partners to figure out how to take those jobs in-house and or some combination. So I'm absolutely not afraid to cancel contracts, particularly when I find patterns of past weak performance. So I'll say that and turn over to Kevin to speak to the details, which I don't know.
Right. Thank you, Secretary, and thank you, Delegate Resnick, for your question. Baltimore City has come a long way since we changed vendors about 7 years ago, I guess now at this point, where the prior vendor had performance that had dropped considerably. We're very happy, at least, that we've seen that this performance has increased over the 7 years with this current vendor. And when making this decision, we take it very seriously. We work weekly with the vendor to monitor their performance. We talk with the issues that they're facing. And we really did, by looking at this and seeing how close they came to making their goal this year in the current support, knowing that the pandemic still had issues and it was outside their control because it was more with the courts, which were closed and we couldn't process cases through the courts timely. We also had the new child support management system roll out during this past year. And knowing that there was some challenges with data conversion and other hindrances that occurred at that time, we also see that that helped limit the performance. So since it was partly on the departments, having our new system be part of that issue, we just feel like this year it was worth not penalizing them for it since it came very close.
So I think the follow-up question to that is, how confident are you that within the next calendar year, the vendor is going to, get with the program, if you will?
I'm very confident that they're moving in the right direction. It is hard to predict for sure, but if they continue to move forward and we don't have other challenges, I do think they should be able to make the goals.
Wonderful. Thank you very much.
Are there any other questions, Chairman, that you'd like me to?
Delegate Heinbaum.
Thank you, Mr. Chairman. I may be out of sequence here, but I'm
Sure.
curious. The salary adjustments that were made back in the middle of November, have you seen any evidence yet that that's improving recruitment and retention, or is it too soon to tell?
I can answer that even though I wasn't here because I've been working very closely with Acting Deputy Secretary Dan Waite on understanding both vacancies and retention. I think the honest answer is it's too soon to tell. However, I'll tell you what some of our plans are to try to turn that around. Just this morning, I was having a conversation with him about the authority that we have instead of Maryland to do same-day hiring, for example, as we do recruitment. DHS has not taken advantage of that mechanism. So the question would be, well, why haven't we? So that's simply saying, I'm going to hire you, and pending the background check. So we have to do better as a department of utilizing existing authorities to help course correct those vacancies as well as retention. We're going to go live with that in the next couple of months, testing it out first at a job fair. We're working with DBAM to test out those ideas. We'll have much richer data for you in the next couple of months to see if even that helps even out some of what we experienced from last fall and through this new year.
Thank you. Thank you, Mr. Chairman.
So I do want to bring, if you, with your permission, this issue of an error. So, my apologies. Yes, ma'am.
Delegate McCaskill, I didn't see you turn on your light. I apologize.
Chair,
Please.
No problem. I slept on it. Great to see you all.
Good to see you too.
Always my pleasure. A follow-up from Chairman Resnick's question. And thinking forward in personnel, I'm always concerned about contractual workout when we can find a way to work it out within a department. And so thinking forward as we clean up, if you will, some of our personnel issues and we start to create a stronger workforce here in the state, do you find that there may be a necessary move to keep contractual workers, or you think that our personnel may not be able to handle the work that's required?
That's a good question, and I'll tell you it's a live one that we're sort of thinking through. One of the things that I asked early on was, what is the existing structure by which we look at all of our contracts across the department, assuming, of course, that we had one. I'm happy to share that the answer was we don't have a robust one across the administration. That doesn't mean that nothing exists, but what I intend to have is a very structured, disciplined way to understand what all of our contracts do, how much we spend, and how they are performing. So then the first sort of task there is how do we create a level setting understanding that when you do business with the Department of Human Services, we expect results. And if the problem is on our end, as Kevin has talked about, let's figure that out and let's transparently address it. If the problem is on the vendor's end, then we have to ask ourselves, is it better solved and done by full-time state employees? I'm personally open to any mix that gets the best results for the people we serve. So I would be remiss to say only contracts or only state employees. I think that we are at a point in time in sort of running governments that it's never either or, it's a little bit of both and I think the first task to be able to sit before you and be legitimate about it is to say, here's what we're doing to try to solve it first. And that's what we got to go to next, is having a streamlined department-wide process that's data-driven, that helps us launch a strategy to answer your question next year far more clearly.
Thank you.
Certainly.
Thank you, Mr. Chair.
So as to the error, and this I always worry that when I say certain words, you're all gonna smile because I think you're not in a good way. So Kevin Geist-White and his staff and others briefed me about an error that has come to our attention, first via calls and email. And the error has to do with the way in which non-custodial parents who have submitted their tax returns have their tax refunds intercepted or stopped. So let me give you some context about what has happened and what we've learned. So first of all, we want to be super transparent about the error because we want to take responsibility for it and help make families whole. We want to demonstrate what we're doing about it right now, live, as we've just learned about this. And then 3, we want to make sure we're reimbursing people if their tax refunds have been stopped improperly. And 4th, to go above and beyond and say if an individual's tax refund has been stopped improperly and there are any fees that are assessed, we will pay back those fees. So the example is that, for example, if Chairman Resnick is a father of children and he has been paying child support is not in arrears, right? Not past due, and he's submitted his tax refund, he expects $1,000 from the federal government and $500 from the state. So then Mr. Resnick learns he's not getting that money. Mr. Resnick calls either the comptroller's office or the IRS and says, "Where's my money?" And they say, "We've taken it to pay your child support." Dad Resnick says, "I'm not behind on my payments. I'm 100% up to speed," proves that he is, and we still took his money. And so the way in which the IRS intervenes on our behalf with Federal Child Support Office, the equivalent of Kevin's work in Maryland, and the way in which the comptroller does, turns out that it's an error, and we think it's a combination of Maryland MD Think and the transition from data from the legacy system. So then we immediately went into, in the last 24 hours, what is the scope and scale of this as tax season is well underway? Turns out that the few phone calls we've received that have come live to either Kevin or his staff or others are beginning to grow. We understand that in doing just a word search since January 1st of this year through today, that there are approximately 398 calls to our customer service center that have had the words of some nature, either tax stop or tax intercept or child support in some way, again, imperfect, but trying to get an indicator and a command of how big this error could be. So in combination with our conversations with Kevin and with Patrick O'Malley on behalf of MD Think as our Chief Portfolio Officer, I thought it was much more wise to bring this to the legislature and the governor's office and be transparent about it than to hide behind it and wait until we find out as people are expecting their tax refund. The people who are going to get those calls are all of you. And they're probably going to be angry calls about why they're not getting their money back, and I understand completely. So as a staff, we have immediately taken control of the issue where we've launched an investigation to understand if it's a data technological error, to get to the bottom of it and find out how to stop it from happening again. We're going to have to be much more proactive about our outreach to those calling the customer service center, and we are hoping it's not thousands of people, but it's in fact hundreds, which is it's never good, but it's better than thousands. So we wanted to bring that to your attention. This is, again, something that we are tackling in the last 24 hours now that we've dug into it. We'll come back to you with a report about how this is working out, and we will do the same thing to the governor's office so that all of you are briefed on what we're trying to do. So I'll pause there and entertain any questions that you might have.
Any questions? Nope. Seeing none, we hope you can get it cleared up quickly and fairly.
Thank you.
Well, thank you all very much. We do have one person signed up to testify, Anissa Alexander, representing AFSCME. Ms. Alexander, are you here? All right, then. I guess we're done with that budget. All right, moving on. For the second budget of this afternoon, as well as the final budget for this subcommittee in terms of hearings. We will hear the Maryland Department of Health's Behavioral Health Administration budget, and Samantha Tapia, as the analyst, presents the analysis.
Thank you, Mr. Chair, and members of the committee. We don't have MD here yet.
I'm sorry? Can you? Yes.
Thank you. So the rest of our team is at the Senate with Medicaid. We had 2 hearings today, so we're just checking to make sure they can make their way here as soon as possible.
Okay. I guess you all have seen the analysis, I imagine, and the team has prepared their response already. So I think we can go ahead and have the analysis presented, and hopefully while that's happening, they can make their way over.
Okay,
Okay, thank you. I appreciate it for letting me know.
absolutely.
Thank you. Why don't we go ahead and get started, Smith?
Okay. All right, again, Samantha Tapia presenting on the Behavioral Health Administration. We are looking at a total budget decrease of $20.1 million, or 0.7%, down to $2.93 billion. But BHA is generally level funded from year to year. We're going to move right into the managing for results issues, looking at Exhibit 1 on page 6. Patient volume in the public behavioral health system, looking at individuals served. There's been a downward trend in across fiscal 2020 and 2021 that was reversed in 2022 with an increase of 4% in total number of individuals served. But this is only a 1.2% increase from fiscal 2019 before the pandemic. And then the number of dually diagnosed individuals treated increased only 0.5%, and SUDS diagnosed individuals treated declined a further 1.3%. So we requested BHA discuss efforts to ensure that those with SUDS diagnoses are able to access and receive appropriate services. Moving to Exhibit 2 on page 7. Substance use disorders. Moving on to the mental health needs, generally, BHA provides an estimate of the number of individuals with serious mental illness diagnosed, or SMI, in the state. The exhibit shows the number of individuals with SMI treated in the PBHS, Public Behavioral Health System, as a percentage of that estimate. The fiscal 2024 report shows a slight improvement in the number of individuals in treatment, at a 1% increase for both adults and children. Moving to Exhibit 3 on page 8, telebehavioral health utilization. This is in rural areas. There is an increase of, over the pandemic, we saw an increase in telebehavioral health utilization, naturally, 30% over fiscal 2020 and 25% over fiscal 2021. But in 2022, we see a decrease of over 9%, even with an increase in total number of individuals served in outpatient settings. And then again, this is in rural areas. So we will probably need to look at another year of data to make any suggestion about patient preferences. But again, only in rural areas, and we are renewing a request from last year for statewide data on utilization of telebehavioral health services. Moving on to readmission rates after discharge. BHA provides, and this is Exhibit 4 on page 10. BHA provides data on the percentage of individuals readmitted to an inpatient facility within 30 days of release from the same or another inpatient facility. And the managing for results goal is that we have under 18% for mental health, general mental health cases, and under 20% for substance use disorder cases. The exhibit shows that the goal has been being met each year, but for SUDS, 30-day admission rate has increased each year from 11.2% in 2020 to over 18% in 2022. So we've asked BHA to comment on efforts to reduce readmissions for SUDS patients and whether lessons applied to reducing mental health readmission rates could be applied to SUDS patients. Moving to medication-assisted treatment services, Exhibit 5 on page 11. Medication-assisted treatment, or MAT, is treatment involving the regulated use of prescribed opioid-like treatment drugs that have been developed, such as buprenorphine, methadone, and naltrexone. The exhibit shows the percent of PBHS SUDS patients utilizing MAT has remained below 30% from 2020 to 2022, with a decrease of 2.2 percentage points from 2021 to 2022. And so, again, repeating another request from last year, recommending a report on the availability of access to medication-assisted treatment, including the distribution of MAT providers across the state. Moving to general budget changes, we have a looking at fiscal 2023, moving into fiscal 2024. Deficiency appropriations for fiscal 2023, we have $256 million for Medicaid behavioral health reimbursements, $67.5 million for non-Medicaid SUDS community services, and $8 million in behavioral health infrastructure investments, which is part of a pair, also an allocation in fiscal 2024 for the same purposes. Then we have some smaller but sizable deficiencies for Shepherd Pratt, the Social Security Disability Benefits Outreach Access and Recovery Program, and to backfill federal stimulus funds for the Midshore Care Traffic Control Platform. We also have a negative deficiency of $20.3 million due to a policy change expanding inpatient hospital services service eligibility for Medicaid reimbursement, and an $85.6 million general fund federal fund swap, which I'll discuss shortly. Then we also have a planned reversion. Under the Medicaid program, claims can be submitted up to a year after the service has been delivered. So we have unspent funds of $70 million allocated in fiscal 2023 that will be reverted at the end of fiscal 2023. Then, as I said, we have the behavioral health infrastructure investments. Related to those is in fiscal 2023, we have a $35 million block of general funds to expand crisis services, and including 23-hour outpatient beds. We have asked for further information on the other crisis funds, the $8 million and $70 million in fiscal 2023 and 2024. And so similarly, we want to ask BHA for more information on the use of this $35 million block in the fiscal 2023 budget. Looking at an overview of spending in fiscal 2024, or the budget, Exhibit 6 on page 14. We have about 3/4 of the budget going to Medicaid provider reimbursement, 72%, or $2.1 billion. Then we have non-Medicaid community provider reimbursements at 26%, or $752 million, and then the rest, 2%, on executive direction and the ASO contract. Looking at more specific changes, or more detailed changes, we have the provider reimbursement decrease of $191.8 million, and then mandated increase in provider rates, $47.6 million. The behavioral health infrastructure investments already mentioned, a difference of $62 million. New state opioid response funding of $39.5 million, and an increase of $500,000 in the 988 line funding, which I will discuss further in issue 2. Looking at, again, at the behavioral health infrastructure investments, again, that was $70 million. So moving on to fiscal 2024, $70 million in general funds is included in the fiscal 2024 budget for the general purposes of improving crisis services, timeliness of court placements, and the issue of hospital overstays. Depending on the more specific uses of the funds, the state may be able to supplement the amount with matching federal fund sources. So we've restricted use of the funds, recommend restricting use of the funds until a report is submitted with more specific information on programmatic allocation and use of the funds toward the previously mentioned goals. Looking at the enhanced federal match, due to the federal legislation a phase out of the enhanced FMAP provided during the pandemic will begin on April 1st. And what this means for BHA's budget is that the deficiency appropriation, there is a deficiency appropriation for, already mentioned, the 85.6 million in general funds, swapping general funds for federal funds, along with a similar swap of 17 million in the fiscal 2024 budget, for a total positive difference of 69 million in general funds for use in fiscal 2024. Then also impacted by the ending of the pandemic is the general fund adequacy for provider reimbursements. The federally mandated freeze on Medicaid disenrollments will also be ending April 1st. And based on our updated, more favorable enrollment forecast, we recommend reducing the funds for provider reimbursements by 40 million. We also have recommended a reduction of a total of 100 million general funds due to a budgeting error in the fiscal 2023 deficiency. Sorry, not in fiscal 2024. Finally, we have federal stimulus funds that were not allocated in the fiscal 2024 budget. BHA was awarded 27.8 and 27.6 million from the American Rescue Plan Act, or ARPA, of 2021 for mental health and substance abuse treatments. So for each of these, approximately 10.2 million was left over from both blocks of funding. So we recommended a reduction in the general fund budgeted for the behavioral health infrastructure improvements by 20 million, and then the replacement of those with the unappropriated federal fund, federal block grant balances. Looking to personnel and the issues. Personnel is pretty straightforward. BHA is unique in being below the budgeted turnover rate. They have vacancies 9 below the budgeted 11.32. They also have 13 new, mostly administrative positions, and contract FTEs reduced by 6.76 positions. Moving on to issues, we have the ASO, status of the ASO, or Administrative Services Organization, recoupment and forgiveness, and then the 988 crisis hotline. The ASO was contracted in July of 2019, launched the service in January 2020 without sufficient testing, and it was nearly non-functional through August of 2020. The administration decided to estimate and pay out reimbursements during that time to support providers, leading to a large number of overpayments and a recoupment effort that started in August of 2020 and is still ongoing today. Original estimated payments were at 1.06 billion after some bill reconciliation, and the amount to be recouped was approximately 360 million in October of 2020. It now stands at 112 million after ongoing recoupment and forgiveness efforts, which began at the end, or the forgiveness plan efforts that began at the end of fiscal 2022. The forgiveness option provided or gave providers owing 25,000 or less the option of forgiveness of their debt. And then the remaining providers were given a number of different options, which are listed on page 21. Exhibit 8 on page 22 shows the distribution of outstanding accounts by balance remaining, showing that most accounts have been paid or reconciled down under 50,000. And Exhibit 9 on page 23 shows the decreasing outstanding overpayment debt over the past 2 years, according to reports requested of and submitted by MDH. Again, from 360 million in October 2020 to the 112 million as of January 2023. The administration plans to continue recoupment and forgiveness efforts through the calendar year 2023 and then send the remaining accounts to the Central Collection Unit. We've asked for commentary on the progress of the new ASO contractor selection and what changes have been suggested and adopted for reforming the contract selection process. And we've recommended restricting funds pending a report at the close of the calendar year 2023 on the actual or estimated status of the provider recoupment and forgiveness process. Moving to the 988 crisis hotline. 988 was established by Congress as the National Suicide Hotline in October of 2020. States were given a year to coordinate state legislation and funding to support state-level operation of the national program. In Maryland, chapters 145 and 146 of 2022 designated the 988 line as the primary suicide and behavioral health crisis hotline in Maryland and established the 988 Trust Fund to fund 988 program development and reimburse participating crisis call center and mobile crisis team providers. Exhibit 10 on page 26 shows 988 call volume for Maryland as reported by the National Suicide Prevention Lifeline since it went live in July of 2021. We can see that 988 call volume has been increasing, and data as of January 2023, not shown in the graph, reflects a further increase on December 2022. Based on the average call duration reported, this exhibit also shows a steady increase in the estimated average number of call hours handled by staff per day in a given month. In terms of funding, $5 million was allocated to the fund for fiscal 2023 and $5.5 million for fiscal 2024. BHA reports that the funds so far have been used to recruit, hire, train, and retain call center staff, coordinate response structure, and improve the call, text, and chat response rate. But we requested BHA comment on whether it anticipates the same or similar uses of funding in fiscal 2024. To review and close, our recommendations include 5 fund restrictions and 1 committee narrative for information requests. This includes the ASO recoupment, status of ASO recoupment at the end of the year, the telebehavioral health utilization, statewide data, access to medication-assisted treatment, the $70 million appropriated for behavioral health infrastructure reimbursements. And then we also have a request for non-Medicaid public behavioral health system utilization data for the use of constructing our forecasts. We have also restricted use of, or recommended the restriction of use of the reimbursement funding to the reimbursement programs, the 3 programs. And then we have the 4 fund reduction recommendations, the $20 million because of the federal fund available, ARPA fund availability, the $40 million in decrease in $40 million based off of our updated Medicaid enrollment forecasts, and the $100 million due to the budgeting error. Other than that, we have brief summaries of the last year's JCR requests, a summary of the ASO, of the audit findings related to the ASO, and an update on the bed registry IT project. And other than that, we concur with the governor's budget. Thank you.
Thank you. And we'll call up the department, Secretary Scott and your team. Oh, I'm sorry. I apologize. Please come on up. No, it's fine. Please come up to the table. But in the meantime, are there any questions for the analyst? No, thank you. And thank you to my wing woman for helping me out on that. Madam Secretary, please begin.
Good afternoon, Chairman Resnick, members of the subcommittee, Laura Herrera-Scott, Secretary of Health. With me is Dr. Lisa Burgess, Acting Deputy Secretary of Behavioral Health, and Chief Financial Officer Emily Brandenburg. Also available for questions are, oh my God, Marshall, I just blinked on your last name. I'm sorry. Ensign. Sorry. We have people here for support. Sorry, I'm still getting everyone's last name. I know everyone's first name. Sorry. I want to thank Ms. Tapia and the entire DLS Budget Health team for their analysis. And before I turn it over to Dr. Burgess, I just wanted to highlight our response to the first prompt and speak to our larger vision for the public behavioral health system overall. So we know COVID exacerbated mental health and substance use disorders in Maryland, and while this increase in disease burden is concerning, it has provided an opportunity for the administration and the legislature to address long stigmatized health problems, behavioral health problems, and seek out solutions to strengthen our behavioral health. In my short time that I've been here, we have a lot of great assets in the state of Maryland, but they are not organized like a continuum of care the way we're seeing in the physical health system, like we see in the physical health system. So that's one of the things that we're looking at, so we can make sure that as people go into the system, there are other connection points, because I think what we're seeing today around these wait lists is a result of having these one-off initiatives that are not connected to other things. We acknowledge additional steps are needed to improve access to both substance use disorder treatment and mental health. Nationally, only 13% of people with drug use disorders receive any treatment, and at the national level, gaps also exist in access to mental health care, with less than 50% of individuals with mental illness accessing treatment in a given year. These treatment gaps are unacceptable, and just as the governor has said, to leave no one behind. That's inclusive certainly of people with behavioral health diagnosis. And we are committed to developing and strengthening the resources we have today to get to a full continuum of care. We are working to make sure individuals with behavioral health conditions can access care through multiple entry points. So 988 is a lifeline, and it's 8 crisis call centers, mobile crisis services that come online this July through a behavioral health, through Medicaid and behavioral health service expansion, as well as increased stabilization centers, crisis stabilization centers. Examples of this approach can be found in the 24-state opioid response initiative statewide, represented in hundreds of community-based organizations, hospitals, and prevention, treatment, and recovery programs that help support our continuum of care. We're in the process of doing an inventory of all the resources we have in the state, not only by where they sit in the delivery system in the continuum, but geographically, to see what else needs to be done to shore up the behavioral health system. So with that, I will turn it over to Dr. Burgess, who will go through in summary response to our DLS questions.
Scott. So the first question regarding the statewide data collection and reporting on the public behavioral health system.
Dr. Burgess, if you can move the microphone just towards you, thank you very much.
Okay.
Appreciate it.
Absolutely. So the first question regarding the statewide data collection and reporting on the public behavioral health system, telebehavioral health utilization, we do have that statewide data. Obviously, you don't have it, so we will make sure that we provide it to you. Thank you for bringing that up. Regarding reduced readmissions for SUD patients and whether or not we can learn from the mental health readmission, we can. And we thank you for bringing that observation up. For example, we have what's called the Maryland Readmission Reduction Program, and that program is in 5 jurisdictions. It identifies individuals who have a mental health diagnosis with increased ED visits, and we deploy care coordinators into the hospitals, whether in the inpatient unit or the emergency department, and we connect them to outpatient community behavioral health support systems. So what we've done is that we have the state care coordination program, and that program actually, again, takes care coordinators. They enter the intensive rehabilitation residential centers, and they work with individuals who are being discharged. They connect them to the community. So as Dr. Secretary Scott was saying, it's very important in the behavioral health system to ensure that we have a continuum of care. And that's what the care coordinators do. That increases the chance that we have a decreased loss to follow up that may occur when an individual does not have that transition team assisting them. Finally, we also have another initiative, and that will occur in July of this year, and that is the reimbursement of peers. Again, peers will assist individuals in being connected to the community supports. I will now turn over the mic to Emily Bredenberg, our CFO.
Thank you, Dr. Burgess. We were asked to comment on how we were specifically using the $35 million that was budgeted in 23 to support crisis response efforts. In 23, we were focused on developing the requirements and regulations for mobile crisis and crisis stabilization centers. And this work took longer than we anticipated, and to date, the funding has not been spent. We are working through our second quarter projections, and we're confirming if part or all or any of the $35 million will be necessary for BHA to close. We were also wanted to respond to the recommendation to restrict the use of $50 million of our $75 million set aside for behavioral health investments, pending a submission of a report detailing more specific use of the funds and determined goals. What we wanted to share with you today is we've developed a plan, and we're reviewing it with the Department of Budget Management and the Governor's Office. And we're hoping to do the same with this committee and DLS well before the July 1st request of a report. And so would prefer to go that path rather than require restriction of fundings and submission of a report. We also wanted to talk about the favorable enrollment forecast and the recommendation of a $40 million general fund reduction to our Medicaid behavioral health budget. We respectfully disagree with the recommendation of a $40 million general fund restriction or reduction. It's a very unusual time for enrollment projections with the Family First Coronavirus Response Act, continuous enrollment requirements, and the federal public health emergency ending in the next 6 months. Future enrollment is more uncertain than typical. However, what we'd like to do is we'd like to work with our partners at both DLS and DBM together and see if there's a reduction that the three agencies can agree to. DLS recommended reducing the general funds budgeted for infrastructure improvements by $20 million and then authorizing MDH to replace these funds with the unappropriate federal block grant dollars from ARPA. And so again, the department respectfully disagrees. The ARPA awards already have an approved budget and a plan submitted to the U.S. Substance Abuse and Mental Health Service Administration, or SAMHSA. And any changes must be approved by SAMHSA. And the plan approved by SAMHSA includes awards to local jurisdictions, 211 Maryland, and specific providers in both 23 and 24 to address state priorities for mental health and substance use disorders. Maryland's budget and spend plan was developed following federal guidelines, and local jurisdictions and other grantees have already received their proposed allocations for fiscal year 23. And BHA is currently reviewing the fiscal year 24 spend plans, their fiscal year 24 spend plans. Some of the projects that started in 23 would continue in 24, so any funding diverted by the General Assembly would halt projects already in place. And lastly, for my portion, DLS was requesting a report on actual or estimated status of provider recoupment and forgiveness at the close of the calendar year, and we concur. We're happy to provide this information.
So then I'll continue with the progress of the new SO. So we have posted the RFP on eMaryland Marketplace Advantage. It closes on March the 16th. We anticipate that we will review those proposals. We will say that, again, referencing lessons learned, that our guiding principles will include prompt payment of valid claims, that we will ensure that the expanded reporting occurs, and this will include data sharing with our MCOs, that we will have auditing, and that will include our having quality assurance and performance measures. Regarding the operational differences between 988 and 211, first off, I will say that definitely 988 and 211 do share the mission of assisting individuals who have mental health and substance use disorder associated crises. 211 was started 3 years ago in Maryland, and in addition to providing crisis services connections, it also assisted residents of Maryland to have a connection with social services. Otherwise, in this day and age, we use the social determinants of health. Also, this service 211 assisted individuals in connecting with non-emergent behavioral health resources. 988 started in July 22, and as we know, that's the National Lifeline service. Regarding MDH, anticipating similar uses for fiscal 2024 funding, yes, we do. We want to support the current 8 call centers. We use those funds to recruit, hire, train, and retain call specialist workforce for the staff. And this is, again, for the 988 Lifeline centers. And I'll turn the mic back over to Emily.
Actually, that concludes our,
Oh.
but we are happy to take any questions. And this concludes, I believe, in this committee as well. This is our last hearing.
This is our last hearing too, yes. Any questions for the department? Vice Chair Shetty.
So much, Mr. Chair. Thank you all so much for being here today. And wow, it feels like we just started budget hearings, so it's amazing that we're concluding them now. So I wanted to dig in a little bit on some of what you shared on 211, please, and the overlap with 988. I had some great productive conversations with some advocates around both, actually, over the last couple of months. And just wondering if you can share a little bit more about 211 specifically, the connectivity to partners and communities and the follow-up that's being done, as well as what the governor's current budget request is for 211, if it's level from prior or increased at all.
Well, I'll start with the questions. Great question. And I will say that I applaud that question because not everyone in Maryland understands 211 and what it offers residents. In addition to, as I said before, assisting individuals who have a mental health or substance use disorder crisis, 211 is a resource for individuals who call that number and they need assistance with, we call them social determinants of health, SDOHs. And so that means if you have need for housing, if your heat is turned off, if you don't have food in the home. And I will tell you that when we were working in COVID and we were assisting providers in what they needed, in addition to information regarding vaccinations, et cetera, the primary thing that they needed was to help their patients get to SDOHs. They needed those resources. So that's what 211 also offers in addition to the crisis services. In addition, and Marshall Henson leads this charge with ensuring that 211 Press 4 is a resource for hospital providers, I use the word providers, who need to ensure that individuals in the emergency department have a place to go. Right. Whether it's an inpatient or outpatient. So to your point, 211 does have more functions than the 211 crisis services. With that being said, in Maryland, because it was here first, individuals do know 211. And so while we are trying our best to ensure that individuals know about 988, there are some individuals who are maybe the slower adapters. And in Maryland, we want to make sure that people have no wrong door. So we want to ensure that individuals who do know 211 feel comfortable with that because they do serve multiple functions that we're measured in the conversation regarding is it either or versus both, or is it a very measured transition?
Sure. It sounds like both teams collaborate in support of a constituent who might call in need of either crisis support and or like a long-term plan on what comes after. My question also is around like connectivity, not just to, so in the event that somebody calls in with multiple challenges and like food insecurity as an example, housing insecurity, as well as behavioral challenges, like, you know, these are often are overlaid. And so it sounds like our 988 teams or 211 teams, they're working together to support access to services that an individual might need, either through the state or even maybe from the conversations I had heard, at least it also sounded like there was connectivity to community resources too. So if someone food insecure might get support enrolling in SNAP, but they also might say, okay, for today, here's a local food bank also that can help support your needs. Can you share a little bit about the tracking and wraparound support services, the following of the individual that's done? Like, are you able to keep up and see how they are doing?
We can see the referral patterns. We don't necessarily see the outcomes once they're at the food bank, for example, to know what the food bank did or what they provided if it was more than the one time. So we're certainly thinking about that. Overall, thinking about the social drivers that Dr. Burgess was just mentioning and the outcomes, and many of you may know there are many companies that help support community-based organizations to connect those services and build those outcomes. So if they went to the food bank, did they get the food that they needed? And if they were referred to SNAP, did they get the SNAP, benefits that they were eligible for? On the latter, we can check within our own systems, and certainly working with Secretary Lopez moving forward on how we do that. But we don't have that as part of the 2-on-1 capacity today, but we are looking at vendors that can do that. So we know the referral was made, but we don't necessarily know the outcome of the referral.
Got it.
Through 2-on-1.
Okay, thank you. Helpful, thank you.
Thank you. Delegate McCaskill.
Thank you, Chairman. This conversation actually sparked an incident. About 2 weeks ago, I took my mom to the emergency room. Fortunately, she's okay. But I was thinking about the sluggishness that we have and the ratings we have in the ER here in the state of Maryland versus the rest of the United States. And in sitting in the ER for almost 14 hours, I had a lot of observation time. And in that observation time, I saw, probably just not being an MD, but identified maybe out of the 20 patients that were sitting in the ER at any given time, maybe 6 to 7 of them were in a mental health crisis. Some of them were even yelling out, "I need someone to talk to." They had been triaged, they had been placed in the ER to sit. And going back and forth with my mom, I noticed those patients were still sitting there that seemed to be in a mental health crisis. And so maybe this is already in place and the ERs are equipped. And of course, we would like to be more proactive and have those mental health patients to get help before they have to go to the ER as the last resort. Usually that's how it goes, right? And not use them as the internal medicine doctor, if you will. But I'm just curious, in thinking back when they were yelling, it was about 3 of them who were yelling out, "I need help, I need someone to talk to now." Is there something that, thinking about the sluggishness of the ER, trying to help those patients at the point of service, and looking like they needed help, appearing that they need help, if they had the access, I'm thinking, to those calls, being able to call someone, and some of them may have had cell phones and some of them didn't, but in their call out for "I just need someone to talk to," I'm thinking maybe if they had someone to talk to on the other line at that point, that someone in the ER could refer them to, it may have helped their crisis and they need not have to see the doctors in the back. So I'm not sure if thinking forward or if it's already in existence, if maybe there is like a booth or something that they could have access to go and push the red button to get immediate access to that phone call when they just need someone to talk to and they're in the ER and they really don't need to see the doctor, if you will, but they need to just have someone to talk to. So I was curious in that observation with all that time in the ER.
So I'll just put it out that we have the worst ER wait times in the country right now, and it's multifactorial, from the staffing shortages that the country is facing to inability to discharge people, so higher lengths of stay, so the worst. To your point about behavioral health, they are triaged like everybody else in the ER based on the acuity of their why they're there. So the ER may have deemed them lower acuity compared to someone that maybe was having chest pain or someone that was having an acute psychotic event, as an example. And so we have a lot of work to do. I think there's a bill floating around studying ER wait times and why is it so bad and what are we going to do to make it better. So it's a complicated question, and your suggestions are one of many that we have to consider. I do think overall we need more education so people know that they have choices other than the ER. So exactly like what you were describing, calling 988 and maybe getting response from a mobile crisis team as an example for a behavioral health condition. But we have a lot of work to do. That your separate area, 988, they're one of many. We just have to figure out exactly what the problem is and why it's taking so long, and then what are all the resources that we need to do better. I can tell you for behavioral health overall, if you look over time in the last 40 plus years, all we've done is cut beds. So it's gotten lower and lower and lower and lower and lower nationally. So no matter what, we have a bed shortage in America, and we have a bed shortage in Maryland.
Thank you, Mr. Chair.
Thank you. I have a quick question on the ASO RFP. I want to follow up a little bit on that. So I appreciate the metrics that you mentioned, and especially the higher data sharing and the more performance measures. I think that's critical. I think that was something that under the current contract was desperately lost. I am assuming that the evaluation criteria for the RFP were published with the RFP, so we know what the evaluation criteria is going to be for selecting the award winner. One of the problems that the current contract had was the selection of what many deemed to be the lowest bidder versus what should have been the best value contract. And I think many of the problems that we have stem from the fact that the current bidder undercut by a significant amount. So is that evaluation criteria been adjusted for this RFP? Are we looking at best value, or are we still looking at lowest bidder, or is there some combination therein?
So we need to follow up on that because most of our contracts are lowest bidder. So it's, you have the technical proposal separate from the financial proposal. And so we have to follow up on that. I don't know the answer to that. I don't know what went in and what was approved, but hear you and agree as far as the value of the contract. You get what you pay for. So we are definitely looking at that. I will say the other thing that will be part of this evaluation process is actually seeing the capabilities, not just reading the capabilities, but them demonstrating their ability to pay a claim to provide the data. So that's built into the long lead time that we have to make a decision to actually demo the capabilities.
Great. Thank you so much. Last chance. Any other questions? Seeing none, thank you very much. We do have 7 people signed up to testify. So we're going to call them up in 2 panels, a 4 and a 3. So when I call your name, please come on up. Lori Doyle, Ann Seacott, Nancy Turner, and Kim Wireman.
Thanks, Mr. Chairman. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. For those who might not know us, we represent 110 organizations that provide mental health and substance use disorder services in the community. Here, unfortunately, to report that we have a number of behavioral health providers that are in financial distress. We've not seen this level of distress before. And it's a combination of the pandemic and of Optum. And Mr. Chairman, you nailed it with the low bid issue, and it's had devastating effects on our providers. And these are providers who've had decades of experience, have very sound fiscal management practices, have quality services, and they are on the cliff. They are on the edge now. They've been through hard times before, but they can't survive the 1-2 punch of COVID and Optum. So we have 2 asks for you today. One has to do with the minimum wage bill. When you all passed the Fight for 15 minimum wage in 2019, it included 6 years of mandated rate increases for 3 provider groups: long-term care, developmental disabilities, and behavioral health. And those were to set from FY21 through FY26. For some reason, the first 2 groups, developmental disabilities and long-term care, got 4% across the board, where behavioral health got 3%, sometimes 4%. There was no real rhyme or reason to it. So this upcoming FY24, we're in for 3%. The other 2 groups are in for 4%. The governor's budget accelerates the last 2 fiscal years, 25 and 26, if the Fair Wage Act of this year passes to accelerate the $15 minimum wage. So 8% would be added to those increases, making ours 11 and the other 2 groups 12. We have written to the governor asking for a supplemental to provide parity with the other groups, not only because of parity, but because we have taken it on the chin with Optum. We have really suffered with Optum, and we did not get retainer payments or other things during the COVID pandemic to insulate us from the financial impact as the other groups did. If we're turned down for that supplemental, we ask you and urge you to use the $70 million, and I know it's not quite 70 anymore, but in discretionary funds in the Behavioral Health Administration budget for that purpose. The other ask that we have is please to resist any effort to delay the rate increase beyond July 1 of this year. Our increase is tied to the Fair Wage Act, but the reality is that our rate increases, or our rates in general, not only pay for our wages, but for everything else, gas, food, rents, all of these things that have been hit by inflation. So we can't negotiate on those costs. So if our rates don't go up adequately, the only place we can turn is to the line item that says wages and benefits, which is exactly what we don't want to do. And I'll just close by saying, we agree with Secretary Herrera-Scott that the dots need to be connected. It's been so much of a focus on crisis services and 988 and doing all good initiatives, but we have failed the things that keep people out of crisis. That's where we ought to be. That's what primary care does. That's what we should be doing. We have a couple bills before you this year. One is a certified community behavioral health clinics, and the other is a value-based purchasing pilot. So we hope you take a look at these because we need to reset the system. Thank you.
Thank you, Mr. Chair, members of the committee. I'm Ann Seacott, testifying this afternoon on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence. We're here in support of the governor's budget, and we welcome the new secretary. You're going to hear from some other folks. A lot of what we've talked about today is focused on the crisis services, and we certainly need to have a lot of focus on crisis services. But please remember that this is a continuum of services that are required to help people through a lifetime. So that includes the crisis response. We need the prevention and the services available to prevent the crises. We need the treatment so that people are able to learn how to manage their chronic diseases. And we need long-term recovery supports as well. We are very excited to work with the new leadership at the department and at the state, over in the State House, to really look at how we manage all of those systems, connecting those dots, appropriately funding and holding people accountable. So we're looking forward to some significant changes in very positive ways over the next few years. So thank you very much for your support as well.
Ms. Turner.
Hi, I'm Nancy Turner. I'm the CEO of Serenity Health, which is a substance abuse program, and Nova Wellness, which is our PRP, which is psychiatric rehabilitation. I come before you today to support as a member of MATOD as well. MATOD is the Maryland Association for the Treatment of Opioid Dependence. I would like to take this time to say thank you for the reimbursement increase and advocate for the budget to cover the cost of rising salaries. There is a workforce shortage, so we are competing desperately within the market for any counselors out there. The market is very slim, so salaries are increasing as well as overhead costs increasing. Optum has been a total train wreck. I'm sure you don't have to rehash that whole event, but I would like to bring up two things that I think could bring some improvement to the market as far as that goes. Authorization turnaround times in PRP are 14 to 30 days. So getting somebody into a mental health program with a care coordinator takes 14 to 30 days. There's no turnaround time shorter than that with Optum. Optum server is unreliable. Between 9 and 5, authorizations drop constantly. So we have a full-time person just for the authorization process from Optum. So I could probably sit here and go over the trauma of Optum with you as a provider of services, but I think we've been through that enough. I hope that you will look at the quality of the ASO coming up, not just the budget of the ASO, so cheaper is not always better. So I'm hoping that we will look at that and come up with a good plan, not just the cheapest plan. And I would like to thank and look forward to working with the new secretary to improve the field in general. So thank you for hearing me today.
Thank you. Ms. Wireman.
I'm Kim Wireman. I'm here from Maryland Addictions Directors Council, also known as MATSI. We're a provider association that represents over 1,500 SUD and dual recovery residential treatment beds, as well as a full continuum of behavioral health care across the state. We're testifying in support of the governor's budget and extend our congratulations to the new secretary. MATSI thanks the governor for including in the budget the 3% increase in rates as directed by the Fight for 15 Act in 2019. And we're very appreciative of the additional 8% rate increase that is available in the budget contingent on the passage of the Fair Wage Act. MATSI wants to underscore the need for funding for rate increases to assist with the governor's accelerated minimum wage. Typically, staff are 65% or more of a behavioral health care provider's expense, which makes additional funding from the state critical to implementing the accelerated minimum wage. With the fentanyl epidemic, lethality has soared and residential clients come to treatment in tremendous need. Approximately 950 people a year each of the last 5 years have died in Baltimore City alone from overdose, with most of those deaths due to fentanyl overdose. Providers need every tool possible to save lives in the opioid overdose crisis. MATSI thanks the governor for funding in the budget the crisis stabilization in 988 to provide crisis intervention to save those lives. We also support reimbursement for peer specialists to increase our continuum of care and the people who can encourage and save lives in outpatient and lower levels of residential treatment. MATSI strongly supports continuing accountability for Optum as providers continue to sort through claims from 2020, 2021, and 2022 due to Optum's system failure. MATSI members also support the continuing use of telehealth. Telehealth allows providers to make the many services needed for clients rapidly, flexibly, and effectively available. Thank you for letting me testify.
Thank you. Any questions for this panel? Seeing none, thank you all very much for coming to testify. We appreciate your testimony. Next, I'd like to call up Nikita Sharma, Michelle Livshin, and Ariel Gordon. Whoever would like to begin first, please.
Good afternoon, and thank you for the opportunity to testify today. My name is Nikita Sharma, and I'm here to represent Be More Clubhouse, a mental health nonprofit in Baltimore City. We work with adults experiencing serious and persistent mental illness and are the only clubhouse in Maryland. The clubhouse model that we follow is all about people, place, and purpose, an integrative psychosocial approach to recovery. Combined with clinical services, the outcomes are reduced hospitalization and mental health cost and improved long-term recovery. On a daily basis, we utilize an accredited evidence-based model that makes use of a work-ordered day where our members, who are our program participants, operate and manage the program with strong peer-to-peer support. Members receive the opportunity and tools to feel empowered and work actively on goals, including employment, education, and housing. Most importantly, though, the strength-based method helps our members regain a sense of self and purpose as they navigate living with mental illness. Our organization is in full support of the Behavioral Health Administration's budget for fiscal year 2024. We're pleased that the administration is providing increased support for community-based behavioral health programming. Be More Clubhouse has previously received BHA funding, and we look forward to working with them again moving forward. It is our hope that we can partner with BHA and elected officials across Maryland to create community and opportunities for individuals living with mental illness by supporting Be More Clubhouse and expansion of the clubhouse model in our state. Thank you.
Thank you, committee members, for your dedicated service, and thank you to the administration for your efforts. We are here in support of the administration's proposed budget. Oh, I'm Michelle Lipshin, Director of Network and Peer Empowerment of On Our Own of Maryland. We're a behavioral health education and advocacy organization of peers, people with lived experience of mental health and substance use challenges. Our network of over 20 affiliated peer-run wellness and recovery centers, funded through Behavioral Health Administration grant contracts, offer free walk-in recovery support services to more than 6,500 Marylanders each year. We want to thank the legislature for granting behavioral health provider increases, which include our centers. For decades, our independent peer-run centers have been able to successfully reach community members with the greatest unmet needs, many of whom are unhoused, uninsured, and experience significant behavioral health challenges. At every center in our network, anyone can get one-on-one peer support and groups, self-help tools, health education, and feel a sense of belonging that can literally mean the difference between life and death. Centers in our network achieve incredible outcomes despite operating on medium budgets of less than $150,000 per year. Our peer-driven program delivers services that meet the unique needs of their local communities. From support accessing and navigating essential services, to reentry supports, to peer workforce training, meal deliveries, and housing support. We can be so innovative, flexible, and responsive because of the annualized funding we receive through the Behavioral Health Administration. And we dedicate every available dollar to direct services. Peer support specialists are an integral component of the continuum of behavioral health care. We must continue to protect robust investment through grants for peer-led programs like ours that are able to reach individuals and communities most in need and which cannot manage the complexity and unpredictability of billing through the fee-for-service system. Now is the ideal time to invest in grant-funded peer-run programs, not only because of the essential support we provide, but because we are training the next generation of certified peer recovery specialists and community leaders. Our peer network is ready to support our communities through the behavioral health crisis, but we must have adequate resources and funding. We strongly urge the committee to vote in favor of full funding of Behavioral Health Administration's FY24 budget. Thank you.
Hi there, good afternoon everyone, and thank you for the opportunity to be here today. My name is Ariel Gordon. I'm the director of the 988 Suicide and Crisis Lifeline Call Center in Montgomery County. Our crisis hotline is a part of EveryMind, which is a nonprofit organization based in Rockville, Maryland. We have positively impacted the mental health and wellness of children, youth, adults, veterans, and families in Maryland for more than 65 years. And we are one of the centers who has answered the National Suicide Prevention Lifeline, which then transitioned to the 3-digit 988 Suicide and Crisis Lifeline for many years as well. After 988 launched in July of 2022, the demand for our hotline services increased tremendously. As we've talked about today, we saw an average an increase in 44% for our call contacts, as well as nearly 200% increase in our chat outreach and 500% increase in the contacts we received via text. This is compared to the same time last year prior to the 988 launch. In the first 6 months of the 988 launch, we received 13,474 contacts overall, and much of that demand was from young folks ages 24 and below. During this period of tremendous increase in demand, funding to BHA and to 988 specifically allowed us to provide better support for our counselors and in turn sustained high-quality service for the people reaching out to 988. We have started to improve our technology systems, and we are working to increase supervision and support to our counselors. Our counselors are part of Maryland's team of mental health first responders. Since the 988 launch in July, we have supported callers, texters, and chatters reaching out in every situation you can imagine. In August, it was a caller who was struggling with substance abuse and was feeling overwhelmed, but needed a non-judgmental ear to hear him out. In November, it was a caller who had reached out repeatedly over the course of 2022 and followed up with us to let us know that he had just accepted a job offer and how glad he was to be here, to have had that opportunity. Despite all of our developments and growth over the past fiscal year, there is still more work to be done. Our interactions do resolve 95% of the time without intervention, but even again with those developments, there have been nearly 1,000 calls that have gone unanswered based on our capacity. So with dedicated and continued funding to 988 through the BHA budget, would allow us to really follow through on the improvements and scaling up that we've started so we can ensure that no calls and no contacts go unanswered. Thank you so much.
Thank you. Any questions for this panel? All right, seeing none, thank you all very much for coming to testify. We really appreciate your testimony. And that concludes all of it. So thank you all very much. There will be, I don't have a schedule yet for the formal decision process on the budget, but that will be coming out shortly, and we will be moving that forward. So thank you all very much. We are adjourned.